Oo nga, dapat dito na.
Wala kang white, ano? Wala kayo ng white board. Mas liliit, sir. Kasi yung problema
Yung angle.
kapag mas pag ganito tayo. May whiteboard ka. White.
Sa 8 cm.
Para pag ganito tayo. Ang magaling ginawa mo siya. Ito yung report mo.
Alam ko pala pa-share po.
Kaya pala parang
Saan ko kuha si David naman? Keeping my heart there. So, yung nasa
Ay, ito.
Ano ba iniwan yung ano? Ano yung iniwan?
Yes, po daw.
Pag dumating na rotator. Ang alam ko dyan, alam ko, under station nangyari. Kasi ang lahat ng station meron. So make sure mo muna pag tayo mag-research. Parang yung may designated na ICU, may designated ko yung isang na-request ko.
Yung speakers inside. Ilain ko.
Sila pa yung alam mo yung hindi pareho tinasimulan na tayo sa Villena. Kasi binili siya all the way na coordinate na lang. Kasi din yung church para mag-survey o mag-team kung alin yung mga areas na meron. Yan, kung gumagana meron sa ICU, meron siya. Gumagana, tapos sa ER, meron. Tapos from there, doon natin malalaman.
Naantay lang po, Dok, if available po yung whiteboard.
Kubayanin natin. Ano na kasi basta kasi baka pero alam ko Lalo naman pa rin. AR, alam ko na. Kaya suppose hindi pagdating dito. But actually, kung tawag sa first education, pagdating dito, kailangan may medicine. Kaya tayo nagdadala kasi every time. It's just parang solution. Para sinusolusyonan mo lang yun. Parang problema. Pag sinunod mo lang yung natin na kailangan pangalan din yung bring up sa friends. Or naman dito may mga header. Kung may kulang sa TNT, yan yung problema. Pag yan ay may friendship, ganun na lang. Or ano mo na lang. If ever kailangan, then ano natin kayo, may kumahan siya, baka siya yung makalapit. Kasi hindi ko kayo masabihan na pumili kayo kasi mo. Diba? Personal yun eh. Gracias kayo para hindi na personally provided mo. Personal na lang.
Dapat yung first year yung dito. While waiting, sir, as iyan ko lang, sir, start yung announcement. Mga ibang may ano lang, ma'am, recording para sa naka-zoom ba tayo? Meron mo din. Sige.
Doctor.
Sa announcements lang po. And we will have an institutional conference in February 27. Awaiting lang po sa final title and sa speaker. That last time sa CD yun tsaka si yun na, sir. Mga letter gagawa ko. Yun ang mga service. Yes. Parang last time.
O yung record. Alisin ko na.
Sit ka. Hinahanap na kaya si academic lang.
Kaya nga, akala ko ba lang siya yan?
Box na po.
Office pag yung percent 10.
Wala na ako.
Hindi ka naman kayo.
Puro carbon
Kaya
dioxide.
pag nandun nga lahat ang konsulat na ang hindi.
Isa nga na bumuhan ng mga tingin ko kay Ma'am Hazel ng yung papers na bali yun na print. Tapos kuha kayo ng scissors. Madami ha. I-cut nyo sa 1/4 sheet magpapakunlawa. Okay. Sa office habang wala pa. Pati scissor rapid. May ball pen kayo lahat. Ano?
Kailangan pa rin yan.
May 1/4 sheet tayo ngayon.
Yan ang mama.
It's rose wine, sir. Line to wine.
Ang mahirap ng ball pen daw yung mga walang ball.
Yung walang button.
Sa ball pen, Sino man ang ballpen? So, walang excuse to. Walang lusot. Wala. Ay, wala. Babati.
Tayo yan po.
Sure.
So good afternoon, doctor. We'll be having our weekly conference. So, topic one, foundation in anesthesia. So, pre-operative communication. So, doctor, followed by painful suggestion, care of president.
Dr. Almazan.
So, we'll start with the
Tapos pa-check ko
prayer.
yun. Next one.
Let us put in focus for president. Heavenly Father, of the day, we travel. It's important to share ideas and to learn from others and our lives. We pray for your guidance as we discuss the matters at hand. May you not only enlighten us, but also through our words and your own. We humbly ask that you continue to bless us that we may fulfill our duties in the service of our patients. May you continue to keep us our patients safe. Everything that we honor you to bring glory to your name, Lord. And this we pray. And also morning to some.
Good afternoon po, doctors. I am Vince Aaron Almazan po, first year resident of Department of Anesthesiology. And our topic for the conference today is preoperative evaluation for patients prior to anesthesia and surgery po. So for the outline of the report, we will cover introduction, approach to the healthy patient, evaluation of the patient with known systemic disease, pre-operative laboratory testing, and patient preparation po. So the pre-operative evaluation has several components po. It should include a review of medical history and physical examination pertinent to the patient and planned procedure po. Based on this information, the appropriate diagnostic test and pre-operative consultation should be obtained. Through these, the anesthesiologist determines how best to utilize or optimize the patient's condition prior to surgery and develop the appropriate anesthetic care plan. Finally, the process is used to sorry. Mali po tayo nabasa. So for the introduction po, sorry. The goals of pre-operative evaluation is number one, to reduce the patient risk and morbidity associated with surgery and anesthesia. Number two, to prepare the patient medically and psychologically. And number three, to promote efficiency and cost effectiveness po. So the pre-operative evaluation has several components. It should include a review of the medical record and a history and physical examination pertinent to the patient and planned procedure. Based on this information, the appropriate diagnostic test and pre-operative consultations should be obtained. Through these, the anesthesiologist determines how best to optimize the patient's condition prior to the surgery and develop the appropriate anesthetic plan. Finally, the process is used to educate the patient about anesthesia and the perioperative period, answer all questions, and obtain informed consent. The preoperative evaluation form can serve as the basis for formulating the best anesthetic plan tailored to the patient. It should aid the anesthesiologist in identifying potential complications, increase consistency in best care practices, and serve as medical legal document. So identifying the patient is the first step when evaluating a patient pre-operatively, typically done with legal name, date, birth, and medical record number. Okay. This includes documenting the patient's sex, sex assigned at birth, gender identity, preferred name, and preferred pronouns. It is important for the anesthesiologist to respectfully address their patient in the manner which they prefer. So assessment of vital signs, height, weight, and BMI provides information regarding physical characteristics, which will be necessary for planning the anesthetic dosages, positioning, and evaluation of coexisting diseases as well as airway management. It is also important to ascertain the nature of the illness or injury necessitating the surgery, as it will also determine both the clinical urgency and proposed operation and influence the available time and depth of the preoperative evaluation. Okay. So this table po shows the classification of the operative urgency. Though individual hospitals po may have their own definitions. The indication for the surgical procedure may also have complications for other aspects of perioperative management po. So emergency po is the classification if it is life, limb, organ saving procedures that should be done within 6 hours. So example po is ruptured aortic aneurysm, major trauma to thorax or abdomen, and acute increases in intracranial pressure. So urgent classification are for conditions that threaten life, limb, or organ, which should be done within 6 to 24 hours po. Examples are perforated bowel, compound fracture, and eye injury. Time-sensitive classification are for stable but requires intervention, should be done in days to weeks. Examples are tendon, nerve injuries, and cancer procedures. And then elective classification are planned at patient or surgeon's convenience up to 1 year po. All other procedures that can be planned in advance. So shown here is our very own preoperative evaluation form of QMMC. So we divide it by section. The first one is the demographic data of the patient. So first, we need to identify the type of the patient and the service that will carry out the contemplated procedure. Then we need to update the patient's data such as name, age, religion, race, civil status, birthday, hospital number, date of admission, address, contact number. Again, this pertains to the demographic data of the patient. The second part on the below the data is the diagnosis and proposed procedure for the patient. One important detail is the diagnosis or the nature of the illness or the injury necessitating surgery, as it will both determine the clinical urgency of the proposed operation and influence the available time and depth of the preoperative evaluation. Next is the planned procedure or the proposed procedure, as this will also dictate the patient's positioning and or whether blood products will be necessary. So the third part of the preoperative evaluation form is the medical history and laboratories of the patient. This include the brief history of the present illness or HPI, past medical history, patient's last meal, last bowel movement for cases such as bowel obstruction or gastrointestinal cases, personal and social history, which includes smoking, alcohol intake, illicit drug use, and allergies to food and medication, and also herbal medications po. The previous anesthetic experience is also important to elicit as it will tell us particularly the presence of difficult airway, history of malignant hyperthermia, and the patient's response to surgical stress and specific anesthetic agents. And the results of diagnostic tests are also important for the clearances prior to operation. This includes blood works, imaging, and ECG po. So although not life-threatening, persistent nausea and vomiting after a previous surgery may be the patient's most negative and lasting memory. It also has the potential to cause prolonged recovery room stay or unplanned hospital admission. There are multiple predictors of post-operative nausea and vomiting, including the type of surgery, anesthetic agent, and patient factors po, which is included in the table po. Others included are female sex, history of post-operative nausea, vomiting, or motion sickness, non-smoking, younger age, less than 50 years old, general versus regional anesthesia, volatile anesthetics, nitrous oxide, post-operative opioids, duration of anesthesia, and once again, the type of surgery. So this is the APFEL simplified score. This predicts the post-operative nausea and vomiting with 0, 1, 2, 3, or 4 risk factors as 10%, 20%, 40, 60, and 80% po. The graph on the middle upper part po. Society guidelines propose dual prophylactic antiemetic therapy when 1 or 2 risk factors are present po. So the prophylaxis po yung table sa lower left po. So 1 or 2 po, risk factors, dual prophylactic antiemetic po ang suggested ng society, and use of 3 to 4 agents po for patients with more than 2 factors po. However po, armed with this knowledge, pre-operatively, the anesthesiologist is also able to tailor the anesthetic or possibly avoid the most likely causes of post-operative nausea, vomiting, which are volatile anesthetics, nitrous oxide, post-operative opioids, and unnecessarily prolonged NPO time altogether po. Okay, so yung table naman po sa lower left po is for pediatric patients po. So in children, Ebert et al. Identified 4 independent predictors of post-operative vomiting. This includes duration of surgery longer than 30 minutes, age above 3 years, history of post-operative vomiting in patient or family, and strabismus surgery. Okay. However, this is the most recent guidelines po, and it includes now 8 factors po. So addition po is volatile anesthetic, post-pubertal female, anticholinesterases, and long-acting opioids po. So for children, most recent guidelines po suggest pediatric patients with 1 to 2 risk factors receive also dual antiemetic treatment or therapy with 5-HT3 antagonist po and dexamethasone po. While those with 3 or more risk factors should receive dual antiemetic as well as consideration for TIVA po. So this is the 4th and 5th part of our pre-operative evaluation form. We perform general survey vital signs, and physical exam of the patient. We also identify the ASA classification and airway management po. So later po, papakita po natin yung ASA classification. And we also assess the height and weight, compute for the BMI, provide this also is important as this will provide us regarding the physical characteristics of the patient, which is also necessary for planning anesthetic dosages, positioning, and evaluation of coexisting diseases as well as airway management po. So this is from the website po of the American Society of Anesthesiologists po. The latest is a physical status classification. So the ASA physical status classification system has been in use for over 60 years. The purpose of the system is to assess and communicate a patient's pre-anesthesia medical comorbidities. The system alone does not predict the perioperative risk, but it is used with other factors, such as the type of surgery, the level of deconditioning. It can also be helpful po in predicting perioperative risk po. So for ASA1, this pertains to a healthy, normal patient, non-smoking, and no or minimal alcohol use po. There are three columns po from the right. So these are example po of comorbidities po that is included in the ASA classification po. So ASA1, wala naman po. Healthy, non-smoking, or minimal alcohol use. And then for ASA, for adults po, this include mild diseases only without substantive functional limitations. So current smoker, social alcohol drinker, or yung occasional alcoholic beverage drinker, if the patient is pregnant, obese, so between 30 to 40 ang BMI, well-controlled diabetes and hypertension, and mild lung diseases po. Okay. So, ASA3 naman po are patients with severe systemic diseases po. So, examples po are one or more moderate to severe diseases. So, diabetes and hypertension but poorly controlled, COPD, morbidly obese, so more than 40 po ang BMI, active hepatitis, alcohol dependence or abuse. Okay po. So clarification lang po, although pregnancy is not a disease, the parturient's physiologic state is significantly altered from when the woman is not pregnant. Hence the assignment of ASA2 for a woman with uncomplicated pregnancy. So ASA4, patients with severe systemic disease that is constant threat to life, sorry. So recent, so less than 3 months, myocardial infarction, cardiovascular accident, transient ischemic TIA, or CAD, or presence of stents po. If there is ongoing cardiac ischemia or severe valve dysfunction, severe reduction of ejection fraction, shock, sepsis, DIC, ARD, ESRD, not undergoing regular hemodialysis po. So, ASA5 are moribund patient who is not expected to survive without the operation po. So this include ruptured abdominal or thoracic aneurysm, massive trauma, intracranial bleeding with mass effect, ischemic bowel in the face of significant cardiac pathology, or multiple organ dysfunction po. So ESA 6 naman po is for declared brain dead patient whose organs are being removed for donor purposes po. So not included here in the table, but included in our pre-operative form is the E for emergency. So the addition of E denotes emergency surgery, and emergency is defined as existing when delay in operation in the treatment of the patient would lead to significant increase in the threat to life or body part.
So in short, pag-E,
Emergency. Ano ba?
so, siya, paano siya?
We add this to the initial classification po. So if it's ASA 2, and then if it is emergency po, 2E po. So the second part of our report is the screening a patient using a systems approach po. First is the airway po. So in the airway, we recognize the potential for difficulty in maintaining a patent airway with a mask, a laryngeal mask airway, or placement of an endotracheal tube when the patient is under general anesthesia po. We confirm also the previous uneventful tracheal intubation. So if the patient has prior history of traumatic or uneventful intubation, and we evaluate the airway po. So this include the oral cavity, the dentition, if it is complete or incomplete, the thyromental distance po, the size of the patient's neck, potential tracheal deviation or masses, ability to flex the base of the neck and extend the head. Okay, so for specific cases such as trauma patient, rheumatoid arthritis, and Down syndrome po, we note this as these are suspect for cervical cord compression po. So we need to take extra care po when examining these patients po for the airway. So this is the modified Malampati classification system. There are 4 classes, 1, 2, 3, 4. And there is a corresponding picture po below. So classification 1, full view of the soft palate, uvula, tonsillar pillars po. So this is the uvula, the soft palate po, and the tonsillar pillars are located here on the side. And then classification 2, soft palate only, and the upper portion of the uvula. And classification 3, Malampati 3, soft palate only, and 4, hard palate only. Intubation involves multiple steps. The flexion of the lower neck, extension of the head of the neck, opening up the mouth to insert the laryngoscope, and displacing the tongue forward down into the submandibular space to expose the glottis. Therefore, a multifactorial approach to predicting intubation difficulty is important, as shown here po. So these are the components of the airway examination that suggest difficult tracheal intubation. So long upper incisors, prominent upper bite, inability to protrude the mandibular incisors anteriorly to maxillary incisors. The distance between incisors is less than 3 when the mouth is fully open. The uvula is not visible when the tongue is protruded with patient sitting. So, Malampati 3 and 4. Shape of the palate, highly arched or very narrow. Mandibular space, non-compliant. Thyromental distance, less than 3. Short neck or thick neck, and limited range of motion of head and neck. So for the pulmonary system, a screening evaluation should include questions regarding the history of tobacco use, dyspnea, exercise tolerance, cough, wheezing, bronchodilator or steroid use, recent upper respiratory tract infection, stridor, and snoring or sleep apnea. The physical examination should assess respiratory rate, chest excursion, use of accessory muscles, nail color, patient's ability to carry on a conversation or to walk without dyspnea. Auscultation can detect this decreased breath sounds, wheezing, stridor, or crackles po. So for the cardiovascular system, the patient should be questioned about symptoms of clinically important valvular disease, such as angina, dyspnea, syncope, congestive heart failure, that would require further evaluation. The presence of unstable angina has been associated with high preoperative risk of myocardial infarction. Importantly, one must identify patients who have undergone placement of a coronary artery stent or an implantable cardiac device to be able to coordinate perioperative management with the cardiologist po. The anesthesiologist should also be familiar with the American Heart Association uh, guidelines for the latest AHA recommendations regarding the specific patients and procedures. The examination of the cardiovascular system should include blood pressure evaluation, measuring both arms when appropriate. The anesthesiologist should consider the effects of preoperative anxiety and review resting blood pressure measurements. For the neurologic system, neurologic assessment in the apparently healthy patient can be accomplished through simple observation. The patient's ability to answer health history questions practically indicates a normal mental status. So questions can be directed regarding a history of stroke, symptoms of cerebrovascular diseases, seizures, pre-existing neuromuscular disease, or nerve injuries. The neurologic examination may be cursory in healthy patients or extensive in patients with coexisting disease. Testing of muscle strength, reflexes, and sensation may be important in patients for whom the anesthetic plan or surgical procedure may result in change in condition. So for the endocrine system po, each patient should be questioned po for history of or symptoms of endocrine diseases that may have perioperative course, such as diabetes mellitus, thyroid disease, parathyroid disease, endocrine secreting tumor, and adrenocortical suppression po. So the next part po of our preoperative evaluation form is the summary of active diseases, review of current medication, and the anesthetic plan and postoperative medications and plan po. Also included are the pre-medications, the IV fluid to be used. Wait po. This also includes the name of the consultant on deck and the residents who referred and interviewed the patient. Okay. And informed consent po. Yes po. Sorry po. Informed consent. Ito na lang po.
Why is it important again to document the neurologic deficits?
Neurologic deficits po, because we want to check po if there are new neurologic deficits po after the operation po, which may be caused by our medications or the anesthetic plan of the patient po.
So, you need to properly document that in your chart, in your pre-op evaluation form. Actually, it's also for a legal basis kasi if something happens to the patient and then hindi nyo nilagay doon, pwede nga sabihin, ay, meron po spinal anesthesia in an obstetric patient. Pwede nga sabihin, after po anesthesia, common to masakit po yung likod ko, wala. Parati po akong merong sakit na nararamdaman sa may putan. So, ilisip nyo yun. Kasi pwedeng pre-op, meron na siya. No? So, it's also protection for you. Kasi, di ba po nasabi nyo before na may sumasakit na din. Simple lang pero syempre, sa mga stroke patients na undergoing neurologic or cranial, pwedeng magkaroon pa ng further damage. No? So, you have to document all of that.
Thank you po, Doc.
And if may I add what Doc Nina said, kasi di ba one of the goals of pre-operative evaluation is to help restore our patient back to their normal function. Kung paano nyo siya nakita pre-op, dapat post-op, ganun pa rin, o mas better. Okay? So, yun in relation dun sa sinabi ni Ma'am Nina. Okay? Dapat ninonote nyo yun sa pre-op nyo. Hindi pwede yung pre-op, asa 1, asa 2, post-op, naging asa 4. Hindi pwede yun. Okay?
Thank you po, ma'am. So for the cardiovascular disease po, nearly half of patients po over 45 years old undergoing non-cardiac surgery have multiple cardiovascular risk factors such as hypertension, hyperlipidemia, diabetes mellitus, obesity, and chronic diseases po. Approximately 5% of these patients have a history of atherosclerotic cardiovascular disease, and there is higher risk of perioperative cardiovascular complications such as death, MI, and stroke. So 3% po of non-cardiac surgeries po. So the goal is to define the risk, to identify which patients will benefit for further testing to determine whether perioperative beta blockade, interventional therapy, or even surgery would be beneficial before the planned surgery, and to form an appropriate anesthetic plan. So in the preoperative evaluation, a clinical history of cardiovascular diseases, diabetes mellitus, cerebrovascular diseases support an elevated risk of MACE or major adverse cardiovascular events. Consistently, advanced age is independently associated with an increased risk of MACE and ischemic stroke. Exercise tolerance remains one of the most important predictors of perioperative risk for non-cardiac surgery, and it also helps define the need for further testing and invasive monitoring. An excellent exercise tolerance, even in patients with stable angina, suggests that the myocardium can be stressed without failing. Exercise tolerance can be assessed with formal treadmill testing or with a questionnaire that assesses the activities of daily living or the MET scoring po. So this is the MET scoring. MET is metabolic equivalence of daily activities. So this is from Barash po. MET 1, daily self-care, patient can eat, dress, or use the toilet, walk indoors around the house, walk a block or 2 on level ground at 2 to 3 miles per hour, or 3.2 to 4.8 kilometers per hour, and do light work around the house like dusting or washing machine. So for MET 1, these are the only daily activities that they can do. So for Met 4, patient is now able to climb flight of stairs or walk up a hill. So faster walking po, can run short distance, do heavy work around the house like scrubbing floors or lifting or moving heavy furniture, and participating in moderate recreational activities such as golf, bowling, dancing, tennis, uh, throwing balls po. And then for Med 10 po or greater than 10, these are patients who can participate in strenuous activities or sports like swimming, single tennis, football, basketball, or skiing po. So again po, this is the ESA classification po. So shown here naman po is the revised risk index or RSRI. RCRI, sorry. This is an update of the Goldman Cardiac Risk Index, and it is a validated method to assign perioperative risk using readily available clinical variables. This tool identifies 6 risk factors po. So, ischemic heart disease, congestive heart failure, cerebrovascular disease, insulin-dependent DM, serum CREA greater than 2, and the type of surgery if it is high risk po. Intraperitoneal, interthoracic, or suprainguinal vascular. So cardiac complications rose with an increase in the number of risk factors present. In patient with an RCRI score of 0, the risk of perioperative cardiovascular complication is 0.4. So greatest naman po if more than 3, the risk is 11%.
It means that what?
The risk po of perioperative. Okay, so it means that if the patient has more than 3 risk factors po, there is higher risk po for cardiovascular events po perioperatively
Perioperatively or
or
operative.
post-operatively. Okay. So for diabetes mellitus po, for those patients with overt cardiac symptoms po, the probability of sorry. Sorry. Diabetes mellitus po accelerates the progression of atherosclerosis po. There is higher incidence of coronary artery disease among diabetics than non-diabetics po. There's also higher incidence of silent myocardial infarction and myocardial edema. And there is the presence of preoperative ECG or the Q waves po. For hypertension, um, hypertension poses increased risk po of LVH, left ventricular hypertrophy, heart failure, ischemic heart disease, CKD, ischemic stroke, intracerebral hemorrhage, and PAD. There is also increased risk of post-operative death and MI. And literature suggests that elective surgery should be delayed if the diastolic pressure is above 110. But the 8th Joint National Committee recommends treatment of elevated BP above 190, 150/90 in patients 60 and above. And treat elevated BP naman po above 140/90 in patients below 60. So, metabolic syndrome or tobacco use. Metabolic,
Does it mean that when you receive a patient kung is 160/90, i-defer mo na kaagad yung permission.
Um, 160/90. I think, Doc, we really need to optimize first the patient po. And we check po if it is the baseline blood pressure of the patient po.
Okay, are you going to defer the or delay the procedure?
Mhm.
Sir, what will be your initial management? Yun lang, kasi, it has been a practice or maybe some sa inyo. Pag nakita nila ang 160, 170, balik niyo muna sa ward niya. Okay. Is that acceptable? Anong gagawin niyo muna? Very easy question naman kayo. Ano gagawin niyo muna?
Chili daw.
Yeah.
Tingnan mo yung kailangan.
Ito pa naman itong scenario natin. Makikita niyo, pupunta, okay, BKA, okay. Or the Prisma. 170, 160 systolic. Papabalik niyo ba sa ward? Di niyo ba tatanggapin? Yung question ko, napakasimple. Ah, pero anong gagawin mo?
Annual.
Yeah. Kasi baka yung first years natin, forget, elevated yung blood pressure upon receiving the patient. Matic, defer, no. You assess the patient if there's anxiety, you give your
Anxiolytics po.
anxiolytics, you can give, apart from benzos, what can you give? For sedation. It's part of your,
Sedation.
ano ba?
Mm,
Aside from benzos, what can you give the patient as a sedative?
opioids.
Opioids, okay. What else? Propofol, grabe naman. Pinakakabahan. O sige, you sedate the patient first. Sedate the patient, more often than not, bababa yun. If hindi pa rin, you can start your Epardipine, you can start your clonidine. Okay, pag di pa rin mababa, that's the time na ipabalik na sa ward. Sabi niya, is corticosterone. Okay? Pero, para maiwasan yung madaming na-defer because of hypertension, you try to manage it first. Okay, pwede naman sa RR muna. Pagpahingahin niyo muna. Then come back at a later time. But not an outright deferral. Okay?
Thank you po, ma'am. So for the okay, so the third part po is evaluation of patients with known systemic diseases po. So for pulmonary diseases po, post-operative respiratory complications po is defined by the European Perioperative Clinical Outcome Consensus. This include respiratory infection, respiratory failure, pleural effusion, atelectasis, pneumothorax, bronchospasm, and aspiration pneumonitis. Post-operative respiratory complications occur more frequently than cardiac complications in non-cardiac surgeries. So routine preoperative pulmonary function test and chest radiograph has limited benefit po. Although chest x-rays identify structural lung abnormalities, these are not frequently associated with significant changes in the management for the general population. In contrast, laboratory studies identifying a reduction in serum albumin levels and increased levels of BUN appear associated with increased risk of perioperative pulmonary morbidity. Um, Epidemiologic studies support the relationship of the anatomic location of the surgery and pulmonary risks. So if the surgery is an open aortic, thoracic, or upper abdominal surgeries po, these surgeries poses the highest risk of post-operative pulmonary morbidity. Emergency surgery and general anesthesia are consistent factors associated with increased risks. Not only can the surgery affect the pulmonary function, but general anesthesia also results in mechanical changes such as decrease in the functional residual capacity and reduced diaphragmatic function, leading to ventilation perfusion abnormalities and atelectasis. So the table on the left shows the preoperative risk factors for
Said open. Upper abdominal. Highest risk for But why is that?
I think, Doc, because these surgeries po is exposing a large part of the lungs po with uh, technically increases the risk po of um, morbidity po, pulmonary morbidity po.
Thoracic siyempre kasi it's a bigger vessel. Pero yung upper abdominal surgery, may high risk for post-operative pulmonary.
I think, Doc, during surgery, upper abdominal po, there is um,
Yes, sir. Post-operative pulmonary. It's not intraoperative. It's pulmonary. Post-operative. That means after the surgery itself, there's a higher risk for pulmonary. Yung upper abdominal.
because of the post-operative pain, Doc. It causes difficulty, Doc, or um, the post-operative pain po after upper abdominal surgeries may have an effect po on the pulmonary function po. Uh, Mahirapan po huminga yung pasyente po. Ay, sorry.
Pinaghalam mo.
Okay po. Upper abdominal surgeries po have increased post-operative pain, which may have an effect po on the ability of the patient to breathe normally or breathe deeply.
Which will, if the patient is not breathing deeply or normally,
Decrease po yung pulmonary function. Atelectasis po.
Hindi
Hindi po.
so it would cause atelectasis. It causes cirrhosis around. Okay?
Yes, sir.
For upper abdominal surgeries, that increased risk for post-operative pulmonary. So, usually pag nalala mo, color. Usually, yan yung magaling kailangan.
Take control.
Ayan.
Oo.
Usually, kailangan pink on color. Without compromising siya. The rest of the color.
Okay po, sir. Thank you po, sir.
Oh, okay. Hindi ba?
Ano yun? Ano?
Sa mga
Ano? Lang, splinting.
The table on the left shows the preoperative risk factors for post-operative reintubation po. So, ASA score, more than 3, emergency procedure, high-risk service, congestive heart failure, chronic pulmonary disease. So, according to Brookman et al., who developed this simple scoring, ASA class 3 or greater, emergency surgery, high-risk surgical procedure, and history of congestive heart failure and chronic pulmonary disease predicts the risk of re-intubation within the first 3 days of after surgery po. So the table on the right po shows the probability of re-intubation based on the score values here. The probability of reintubation with a score of 0 is 0.12% po. If it is 7 to 11 points, the probability of reintubation is 5.86%. So this is within the first 3 days after the surgery. So smokers without chronic lung disease show increased carboxyhemoglobin levels, decreased tracheal ciliary function, and increased sputum production with nicotine-induced stimulation of the cardiovascular system. Although cessation of smoking for 2 days can decrease carboxyhemoglobin levels, abolish nicotine effects, and improve mucus clearance, smoking cessation for 4 to 8 weeks appears necessary to reduce the rate of post-operative pulmonary complications. So recently, vaping has become popular among young adults. While no larger studies are available at this time, there are reports of increased airway reactivity and complications under anesthesia due to pulmonary interstitial changes from e-cigarettes use po. For asthma, during the patient interview, it is important to elicit information regarding the inciting factors, the severity of the asthma, reversibility, or the current status of the patient with asthma. So, frequent use of bronchodilators, hospitalizations for asthma, and requirement for systemic steroids are all indicators of a more severe disease. In addition to bronchodilators, perioperative steroids are worth considering as prophylaxis for the severe asthmatic, starting at least 48 hours prior to surgery for optimal effectiveness. OSA or obstructive sleep apnea, it is a syndrome defined by periodic obstruction of the upper airway during sleep, leading to episodic oxygen desaturation and hypercarbia. So because of their propensity for airway collapse and sleep deprivation, patients with OSA are especially susceptible to the respiratory depressant and airway obstructive effects of sedatives, opioids, and inhaled anesthetics, both intraoperatively and postoperatively. So this is the stop bank questionnaire po, which It is used to identify patients at risk for OSA po. So, if there are 3 to 4 positive answers, there's intermediate risk for moderate to severe OSA. And if there is more than five or more positive answers, there is high risk for moderate to severe OSA. So there are multiple management decisions to make in coordination with the surgeon with respect to the OSA patient. So we can consider a less invasive procedure to limit opioid need. We can evaluate the feasibility of regional anesthesia, uricial or local anesthesia to decrease the amount of anesthesia or opioids. We can review the benefit to risks of non-steroidal anti-inflammatory agents, NSAIDs. We can evaluate the safety of outpatient surgery and plan for perioperative CPAP support and plan for post-operative ICU or monitored unit. So to evaluate patients with endocrine diseases, so number one po is diabetes mellitus po. So the goal is to avoid hypoglycemia, prevent ketoacidosis, and avoid marked hyperglycemia. So metformin, sulfonylureas, uh, repaglinide, GLP-1 agonist, DPP-4 inhibitors, these should be continued until the last day before surgery, but held on the morning of the surgery. So SGLT2 inhibitors such as empagliflozin are associated with euglycemic DKA in the post-operative setting. And this should also be discontinued at least 24 hours po. We also discontinue short-acting insulin while fasting, but may continue subcutaneous insulin infusion pumps at the lowest basal rate po. So all oral hypoglycemics po hold uh, on the day of the OR po. So for thyroid diseases, mild to moderate thyroid dysfunction probably has minimal perioperative impact. A significant hyper or hypothyroidism increase perioperative risks. Preoperative evaluation should clarify the patient's current medical therapy as well as any recent changes. Additional preoperative thyroid function testing is not needed if on stable medication dose and was assessed as being euthyroid within the previous 6 months. If clinically indicated, TSH assays are best for hypothyroidism, while FT4 and FT3 and TSH are best for hyperthyroid patients. Surgery, stress, or illness can precipitate myxedema or thyroid storm in patients with untreated or severe thyroid dysfunction. Elective surgery should be postponed until the individual is euthyroid. If the surgery is urgent, hyperthyroid patients can be treated with beta-adrenergic blockers, antithyroid medications, and corticosteroids. All thyroid replacement therapy and antithyroid drugs should be continued on the day of the surgery. So for AKI or acute kidney disease, AKI is suspected in patients with sudden decrease in the renal function with the possible decrease in UO or urine output. And AKI may occur in individuals with or without CKD. Pre-renal, renal, and post-renal classification allows for a systemic approach. Okay. So pre-renal, AKI, Bu-in-Crea ratio of 20, more than 20. Common etiologies or causes are hypovolemia or hypotension. So, the fourth part is preoperative laboratory testing po. So, no routine laboratory or diagnostic screening test is necessary for pre-anesthetic evaluation. Preoperative diagnostic tests should be selectively ordered based on the patient's medical history, planned surgery, and expected degree of intraoperative blood loss. Testing should be for the detection of specific clinical indications that, that may increase perioperative risks. So, these are the clinical considerations for laboratory testing. So, for blood count, we can consider requesting for CBC among patients of extreme age, if patients with liver or kidney disease, history of anticoagulant use, bleeding or hematologic disorder, malignancy, and type and invasiveness of the procedure. So for coagulation studies po, we can request this especially among patients with liver or kidney disease, bleeding disorder, anticoagulant use, and patients on chemotherapy. So serum chemistries po, such as glucose, electrolytes, renal and liver function po, for patients with liver or renal disease, diabetic patients, patients on diuretics, digoxin or steroids, central nervous system disease, endocrine disorders, elderly, malnourished patients, and the type and invasiveness of the procedure. So chest x-ray naman po is important among patients with current pulmonary disease or clinical manifestations of a pulmonary disease, unstable cardiovascular disease, and type and invasiveness of procedure. So ECG naman po for patients with cardiovascular disease or clinical risk factors, pulmonary disease, and type and invasiveness of procedure. And pregnancy test for possible pregnancy. So for patients in the reproductive age po, especially patients with abdominal pain.
Parang ano,
Nakulit na pa. Ito. Okay. So the fifth part is preparation. So smoking cessation or encouraging patients to cease smoking po during pre-operative evaluation po is one of the best way to advise patient to stop smoking po. We can encourage the patients to stop smoking during pre-operative evaluation by explaining to the patient that smokers have increased risk of cardiopulmonary complications, impaired wound healing, and infection. Okay, so these are the drugs that we can continue or discontinue. So we can continue beta blockers, anti-anginal drugs, and statins po. And discontinue po, blood thinners, heparin, warfarin, low molecular weight heparin, clopidogrel, dabigatran. Okay. Hypertensive meds po, ACE inhibitors and ARBs, and metformin po.
Question, paano yung mga herbal?
Herbal po also, it is best to discontinue po. All of herbal. Because herbal medicine po, contents of herbal medicine are not
Diba? May mga ibang patient. O, Dok, nagtitake po ako ng mga supplement, mga garlic, hindi ko alam, ginkgo biloba,
Yeah.
o ano yun.
I think we should discontinue.
Bye. Dun sa chapter ng
Discontinue po because we're not sure if there is interaction po. Since we're not sure of the contents of herbal medicine.
sample, yung mga nagtitake ng mga garlic supplement, ano. Kasi, di ba, hypertensive sila, so garlic supplement sila. So, papastock mo siya pre-operatively.
Mm.
Eh, garlic lang naman yun.
Mm.
Ano? Kasama sa chapter ng report ko. Ano?
Hindi ko na-indicate daw.
Kasama yung herba. Tapos nagtataka kayo, peri-op, bleed ng bleed yung pasyente. Diba? You have to be careful kasi nabanggit mo kanina, diba, herbal drug. So you have to know yung ano, mechanism of action ng mga herbal drugs. Like yung garlic, ano siya? Nag-i-inhibit siya ng platelet aggregation. So pwede kayong mag-bleed. Okay?
Okay po ba?
So i-include mo rin siya.
I'll edit po and post another PowerPoint po sa GC. Okay, so for blood thinners po, meron po specific time frame of holding. So heparin 12 to 24 hours, warfarin 4 to 5 days. Molecular weight heparin 6 to 8 hours if prophylactic, 24 hours if therapeutic. So for clopidogrel po 7 days, ticlopidine 14 days, dabigatran 1 to 2 days, glycoprotein 2B3A antagonist 24 to 48 hours, 1 to 2 days. Okay po.
Source mo dyan.
Ito ko lang siya sa
Ano?
laptop mo.
Ano in third? O, anong source mo dyan? NY Sora ba? Sa guideline ba? ASRA guideline ba? Kasi mas better ata kung
I'll check ulit po.
siguro mas better kung
Lagyan ko pa ng
yung
reference.
ASRA guidelines kasi
Okay.
yung low molecular weight na prophylactic, I think it's 12 hours, di ba, Dok? Iba-iba kasi. Yeah, so 12 hours per day. 12 hours. Pero sana mas maganda kung yung
ASRA guidelines po.
So there are two actually different guidelines for discontinuation of your anticoagulants. There are differences between your NYSORA recommendation and your ASPA guideline. Saka may updates yun eh, so nag-iba.
Okay po. Thank you po.
check mo,
ma'am. Yes po. ma'am.
That's post mo.
post
Yes,
mo,
po.
ha?
Edit po.
Na important kasi siya.
Especially in our, yun nga, yung patients who have recently had MI or stroke, sila yung nakaganyan, gravidocardiac patients that you're going to put your epidurals in. So that's very important.
So for the summary of fasting recommendations for all ages to reduce risk of aspiration po. Clear liquids po 2 hours. So included po in clear liquids are water, juices without pulp, coffee, tea without milk, carbohydrate drinks. Alcohol is not included po. Breast milk po 4 hours. Okay. And then like if light meal po 6 hours. And if fatty or fried foods naman 8 hours po.
How about your, Yung mga almond milk, like that. I don't know, wonder kasi ngayon, gusto siya, diba? Almond, coconut milk, ano pa yung milk niya? Oat milk.
Oat milk.
Ilang hours kaya siya? Saan mo
So,
siya ilalagay?
sa non-human milk po, 6 hours po.
Alright.
Diba?
Vegan. Ito siya.
Faster practice.
Yeah,
Tayo mo.
the molecular weight mo, diba? It's 10 to 12 hours.
Sa brush.
Oo. Sino?
Skip po.
Go na.
So, pre-operative medications po. So, for prokinetics po, the ESA recommendation po is the routine pre-operative use of gastrointestinal stimulants to decrease of risk of pulmonary aspiration in patients who have no apparent risk for pulmonary aspiration. So this is not recommended po. Example po of
Yun. Sino yung mga
stimulant, ano ba, for gastric motility po, metoclopramide po. Okay.
Sino yung mga no apparent increased risk for pulmonary aspiration? What type of patient?
Elective, patients for elective operation.
So pag sinabi ko, doc, for elective operation ako.
Asawa agad.
Aso.
Asawan ako. Ano yung tatanong mo? Paano mo yung mga tingin mo na, ay, hindi to, low risk for pulmonary aspiration to, so no need na for, prokinetics, kasi nabasa ko sa ASA recommendation. Hindi na ako magbibigay. So, yung mga patient na yun. Sabi, di-discuss mo ba? Hindi.
Abdominal surgery, increased risk or not?
Yes po.
Diabetes, increased risk or not?
Yes po.
So, lower limb surgery.
Yeah, you have to,
Lower limb surgery.
No.
Mm.
Decrease. Not.
Low risk, decreased risk, increased risk or not? Low risk. So, sino ang pwede mong bibigyan? Yung lower limb risk? Lower limb surgery na walang diabetes. Okay.
Na hindi obese. Yes.
Yes.
Sige, pwede.
Okay.
Kasi di ba sabi ang goal din ng pre-operative is you have to be cost effective. So bigay tayo ng bigay, di naman sample, di ba? Lower. Yun, paano?
Increase.
He gets.
Yes po. So,
Same with your,
same thing.
same with your,
Antacids, diabetic.
Follow natin. Another comment.
Yes po. So, pre-operative pharmacologic preparation is as elusive as the ideal anesthetic technique. The patient's psychological condition, physical status, age, and prior response to the present drugs must be considered. The timing and route of administration of pre-operative medications are important. So, benzodiazepines po, these are GABA agonists po. There's relatively little depression of the ventilatory or cardiovascular systems with pre-medication doses. So it can produce anxiolysis, anterograde amnesia, and sedation po.
What is anterograde amnesia?
So from the time of giving the drug po, the start of amnesia po. Ayan.
Kung nakatulog siya,
Ay.
nakatulog.
Ah,
Sa midawan yun, natulog. Diba? God produce and terrorist and siya.
probably not po.
Should only work kapag nakatulog yung pasyente niyo. Pag hindi, at wide awake, kahit yung midawan binigay niya na, dahil lahat ng sinasabi niyo, ginagawa. Okay? Dahil na kayo para parating midawan yung midawan.
So, diphenhydramine, these are histamine 1 receptor antagonists. It blocks the peripheral effects of histamine. So it has a sedative, anticholinergic, and antiemetic activity. So opioids, most frequently used fentanyl, may be used to provide preoperative analgesia. Okay. So these are useful to ameliorate the discomfort during regional anesthesia also, or during the insertion of invasive monitoring catheters or large IV lines.
And not only fentanyl, ha? But you can use your agonist antagonist like pain and what we have before. So, ang pansin ko kasi sa inyo, parati kayo midazo lang 1 or 2 lang. No? Ang sinasabi ko nga, if you're not going to put morphine intrathecally, no? Bakit hindi tayo nagbibigay ng Novain when you're giving morphine intrathecally?
Kasi,
Antagonistic.
Antagonist nga siya, you know? So, it will just counteract the effect of your morphine. So, yun nga, kasi marami tayong drugs, armamentarium. You use that. Hindi lang midas, bago kayo mag-spinal or epidural. Other regimens, we can give Wellbutrin plus Difen or Nalbu plus Difen. Pwede din yun. No? It depends on what your goals are. No? Tulad ko, practice ko, I give that. Bago ako mag-spinal, and then after ng baby out, that's when I give the midazolam. Para na-remember pa rin ng mommy na lumabas yung baby niya, umiyak. Okay? So, doon ko siya bibigay. So, marami, you can experiment actually on what you want. Hindi lang masanay kayo, puro midas-midas lang. Diazepam, di nyo rin ginagamit. Para pag lumabas kayo, nag-DOH kayo. Diazepam lang yung nandun sa hospital nyo. So, try nyo rin. Kasi, this is the time na makikita nyo yung effect sa patient nyo. Mas maganda na dito pa lang nakikita nyo na kaysa lumabas kayo, hindi kayo familiar dun sa drugs, mas matatakot kayo kasi mag-isa na lang kayo sa labas. Okay?
So, anticholinergics po, historically used when inhalational anesthetics produce copious respiratory tract secretions and intraoperative bradycardia. Okay, so indications are anti-shalagogog. Anti-shalagogog. Anti-sialogog. Yeah. Anti-sialogog effect. Sedation and amnesia and vagolytic effect.
What is that? Decrease secretions. So, anticholinergic is what?
ano siya?
What drug?
Atropine.
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 Okay. Everybody has one part na. Part 1. Lahat ng balls, sino ng balls? Wala? Okay. Lahat meron na. 1/4. Ready na? Ay, natingin na.
Wait lang.
Give the answer. Patient with
Support.
BMI sa classification. Patient with BMI is 30. Right, number 2. Patient had MI 2 months ago. Patient had MI 2 months ago. What's that? Patient. Like, these balls pa yun. Number 3. Preeclampsia severe. What's the answer classification? Preeclampsia with severe features. Number 4. Give the Malampati score when only the soft palate is visible. Give the Malampati score when only the soft palate is visible. What Malampati score is that? Number 5. Give one component of stop band. One lang, dami nun. Give one component of stop band. Close mo naman. How many days should Coumadin be stopped prior to surgery? What's Coumadin? Warfarin. How many days should you stop Coumadin or warfarin? Number 7, give one risk factor for PONV in adults. Okay. So, one risk factor for PONV in adults. Number 8, with an ACTO score of 1, there is 20% risk for PONV. What is the recommended preventive? With an ACTO score of 1, there is a 20% risk for PONV. What is the recommended preventive? Ulit Number 1, give the AXA patient a BMI of 32. Review your answer. Number 2, patient who had MI 2 months ago. Number 3, preeclampsia severe. Number 4, Malampati score when only the soft palate is visible. Number 5, one component of stop bank. Number 6, how many days should you discontinue warfarin? Number 7, risk factor for PONV in adults. Number 8, ACTO score of 1, 20% risk for PONV. What is the delta? Okay na. Change paper. Number 1, BMI 32.
Nasa 2.
BMI 2 months ago.
3. Asa 3 to.
Malampati score. So, italat 3. One component of stop bank. Pakialis.
Male sex.
Stop bank. Paper. Sila.
Nag-type na lang kami doon.
Stop bank.
Yan.
Okay. Number 6. How many days should warfarin be stored? 4 to 5. 5.
One to seven. Isang lang.
Number 7. One is factor for QMB.
Female sex.
Number 8. Actual score.
Lancetron. Exam.
Next, 5. Okay, yung minute naman.
So, good afternoon, doctors. I am JV Villena, a year level 2 QMMC anesthesia resident here to report on patient positioning. At the end of this report, we will be able to describe the commonly used positions utilized during surgery and the pathophysiologic effects of each position on the patient, and describe the ways to prevent position-related morbidities. Positioning in a patient for a surgical procedure is a shared responsibility among the surgeon, the anesthesiologist, and the operating room staff. This is frequently a compromise between what the anesthetized patient can tolerate, both structurally and physiologically, and what the surgical team requires for surgical access. So it's a compromise between those two. It is very important for us to understand the physiologic and potential pathologic consequences of patient positioning. Mechanical changes in patient positioning may cause stretch of neural tissue, which is an important factor in the development of peripheral and central neuropathies. It is important to note that stretch of many mammalian nerves up greater than 5% than their normal resting length has been shown to repeatedly lead to central and peripheral neuropathies. Also, another mechanical change in patient positioning, point pressure on soft tissues could cause regional tissue ischemia. Physiologically, it is important to note that physiological responses have evolved to blunt the hemodynamic effects of positional changes to maintain perfusion to the brain and vital organs regardless of posture and position. But this is in the unanesthetized patient. But but in the anesthetized patient, many different anesthesia and anesthetic agents can blunt these compensatory pathways. Therefore, patients under anesthesia, a patient changes in position may cause a more exaggerated hemodynamic response as compared to the general population. These are important for us to know as anesthesia providers for us to be able to maintain physiology and avoid pathologic injury. To reiterate, all positions used for surgery, be it supine, prone, lateral, can cause cardiovascular and pulmonary changes. We begin our discussion with the supine positions and its variations. So this is the supine position. It is the most commonly used position for surgeries. Please note that the head, the neck, and the spine all retain neutrality. The arms can be abducted or adducted, but should be placed in a neutral position as much as possible. When adducted away from the midline, the arms are securely placed towards the midline. The arms are securely placed next to the body. Kaya, at times we tuck the patients dito sa kirino. And when abducted, when the surgeon requires abducted arms, it should be kept to less than 90 degrees as to prevent brachial plexus injury. Attention should be given to pad the bony prominences as well. Eto, in arm positioning, ganyan. If abducted, dapat less than 90 degrees to avoid injury to the brachial plexus. And when adducted, usually what they use is a draw sheet, pero sa atin dito yung tucking rope. So these are the pressure points that are important for us to recognize when the patient is in the supine position. These are the bony prominences that protrude toward the operating table: the occiput, the scapula, the thoracic vertebra, the sacrum and the coccyx, the olecranon process, and the calcaneus. But it is very lucky for us here in Quirino because most of our surgical tables are already padded. They have mattress pads that are sufficiently buoyant and thick enough to allow dispersion of the point pressures. Physiologically, when changing from the upright to the supine position, first here in orange, when changing from the upright to the supine position, the blood pooled from the lower extremities, imagine nyo, hihiga ka. So the normal blood that are in the lower extremities are evenly distributed in the horizontal axis of the body. It goes towards the heart, increasing preload, stroke volume, and cardiac output. Arterial blood pressure increases because of this, but this also causes activation of the afferent baroreceptors by the ninth and the 10th cranial nerves to reduce sympathetic outflow. When sympathetic outflow is decreased, parasympathetic impulses to the sinoatrial node increases. So this causes a compensatory decrease in heart rate and cardiac output. This happens in the non-anesthetized patient. But in the anesthetized patients, especially under general anesthesia, muscle relaxants, or patients under positive pressure ventilation, racial blockade, all interfere with the venous return to the heart, arterial tone, and autoregulatory mechanism. So we can see a more exaggerated hemodynamic response in the anesthetized patient. So these are the things that we have to watch out for. Pulmonary for the pulmonary concerns in the supine positions affect the pulmonary physiology primarily related to the cranial displacement of the diaphragm by the abdominal contents. So when you lie down, the abdominal contents are in the horizontal axis. They are more freely, they can freely push the diaphragm towards the head. So displacement of the diaphragm. This this decreases functional residual capacity by 0.8 to 1 liter. So FRC decreases by 0.8 to 1 liter. In addition to that, induction of anesthesia, be it general or neuraxial, further decreases functional residual capacity to 0.4 to 0.5 liters. So for us to be able to combat this and prevent atelectasis, positive pressure ventilation can be given in patients in the supine position if for general anesthesia. So, in summary, I placed a table there for you para mas madali nyo aralin if you wish to do so. There are several variations of the supine position. We have the contoured or the lawn chair, the lateral uterine or the abdominal mass displacement supine position. We have the lithotomy position as well with its 4 variants: the standard, the low, the high, and the exaggerated lithotomy positions. We first start with the lawn chair position. This is when the patient's hips are at the break of the table. You notice the patient here and his hips is at the break of the table. This reduces stress on the back, the hips and the knees as they are in the flex position. Sometimes this position is better tolerated than the full supine position. We also see better venous drainage in the lower limb as they are slightly over the heel of the heart, and abdominal wall tension is reduced as the xiphoid to the pubic distance is reduced as well. Uh, it is important to note here, the trunk thigh hinge is angulated at 15 degrees. This is the only difference it has with the supine position. The trunk thigh hinge is angulated 15 degrees. This is a 15-degree angulation. Next is the lateral uterine or the abdominal mass displacement. With a patient in the supine position with a mobile abdominal mass, such as a very large tumor or a pregnant uterus, this mass or the gravid uterus can rest on the great vessels of the abdomen and compromise circulation. This is known as the aortocaval syndrome or the supine hypotensive syndrome. This will typically manifest as hypotension due to the compression of the great vessels. If you can see here in this picture, the gravid uterus is compressing both the inferior vena cava and the aorta. This will typically manifest as hypotension due to the compression of these great vessels, and as a compensatory mechanism, heart rate will increase to re-establish a normal mean arterial pressure, producing tachycardia. A significant degree of perfusion can be restored if the compressive mass is rolled towards the left hemiabdomen by leftward tilt of the tabletop or by a wedge placed on the patient's right hip. So as you can see here in the full supine position of a of a pregnant patient, you can see that the great vessels are compressed. One thing you can do is to put a 15-degree incline in the patient's right hip to at least dislodge the entire mass of the gravid uterus away from the great vessels, thus restoring hemodynamic balance. If you don't want to do this, you can also do this. You displace the uterus. You stay by the, you have two ways to do uterine displacement. First is the L method. As you can see here, you stay on the patient's right side and you push the uterus towards the patient's left side. But please note that hindi siya fully to the left. You angulate your hand as well, pushing to the left upward. The same is true if you want to use both hands. You stay on the patient's left side naman and you pull the uterus to you towards the left pero cephalad pa din. All these techniques will displace the gravid uterus away from the great vessels, maintaining hemodynamic stability. Papansinin nyo to if, especially when you're in OB already and before ka mag-induce or kaka-induce mo lang, magtataki bigla yung patient kapag fully supine. Makikita nyo yun, parang magic eh when I first encountered it. Ang bilis. Nagtake yung patient, tas when you do uterine displacement, magno-normalize agad yung heart rate ng pasyente. So, the next variation of the supine position is the lithotomy. The lithotomy position is a variation of the supine position with a
Sorry.
yes po, Doc.
What's the best time to do your uterine It's the best time to do your left uterine displacement. Sorry. Sige.
Usually this occurs after 20 weeks age of gestation po, Doc.
Hindi, that's it.
Okay.
After spinal anesthesia kasi. In OB patients when I observe you, pupunta kayo kagad sa harap, sa head ng patient. So the best time to do that is after your spinal.
Post-induction na po.
You're talking to the patient, how are you feeling? Tinetesting mo yung sa legs. I-displace niyo muna. No? Mas maganda kung gano'n. You practice that. Saka also, since nasa topic tayo, you to practice also na before nyo sabi yung patient, hawak kayo sa pulses para alam nyo yung strong yung pulses niya, kung weak na ba siya. Tapos after din ng spinal, maganda, nakagayon kayo, tas hawakan nyo yung pulses. So yun, it's good practice to do your left uterine displacement right after your sub, habang ina-assess niyo yung level of anesthesia. Okay?
Noted po, Doc. Thank you po. So, in the lithotomy position, the legs are separated and the hips and knees are flexed. The arms are either tucked inside in at the sides or abducted on arm boards. This is commonly used for gynecologic, rectal, and urologic surgeries. So, in the lithotomy position, venous return is usually increased because the blood pooled in the lower extremities are pushed towards the horizontal axis of the body again. So the venous return increases at this point. But that leaves you with a problem. If the patient stays in this position for a prolonged period of time, the patient may suffer from either local ischemia, regional tissue ischemia, or peripheral nerve neuropathies. Particularly, the most common of which is the peroneal nerve neuropathy. Uh, Usually, the peroneal nerve is experiences pressure using stirrups, not this particular stirrups, but the actual stirrups, especially what we used in OB. If you see the stirrups in the labor room, if the patient stays in the lithotomy position for more than, evidence suggests that more than 4 hours na naka-lithotomy position yung patient, the peroneal nerve at the level of the stirrups can cause peroneal nerve injury, and this may manifest as foot drop.
Common peroneal nerve.
Yes, Doc. Common peroneal.
And superficial distal.
Yes, Doc.
So, aside from your obstetric patients, sino pa yung madalas naka-dorsal lithotomy sa atin?
Si Krista. Sorry.
sa patients natin, sino pa yung madalas naka-dorsal lithotomy? Euro,
Colorectal.
din madalas. Which manifests as,
Foot drop po, Doc.
and kasi fulminant na yung foot drop eh. Ano pa yung sa niyang manifestation?
Initially, with peripheral neuropathies, they usually manifest first as paresthesias, weakness, and then specifically for the common peroneal nerve neuropathy, foot drop po. For the low lithotomy, the patient is placed in the supine position with their legs raised and abducted in a crutch-like or full Fowler leg stirrups. The angle between the patient's thigh and trunk is not as acute as with the high lithotomy position, but this is used in vaginal procedures, perineal access, and transurethral instrumentation. Physiologic responses of the body in patients with the low lithotomy are almost the same as those with the standard lithotomy. So this is the full lithotomy position. Frequently used for procedures that require a vaginal or perineal approach. The patient is in the supine position with the legs raised and abducted by stirrups. Once the feet are positioned in the stirrups, the footboard is removed and the bottom section of the bed is lowered.
What procedure na ginagawa? Sa pediatric patient, what procedure ito ginagawa? Maybe hindi niya pa nakita. Pero pull through,
Abdominal pulse through
abdominal pull through for
imperforate anus.
imperforate anus.
Imperforate.
So hindi pa nakita, walang gumagawa pa yun. Pero yeah, ako nakita na ako nito. Sa sa infants yan, madalas.
And this is the exaggerated lithotomy position. This is used usually for transperineal access to the retropubic area. The patient's pelvis are flexed ventrally on the spine and the thighs almost forcibly flex on the trunk. The long axis of the symphysis pubis is almost parallel to the lower legs aimed skyward, so they are out of the way. So this is the exaggerated lithotomy. Another complication if using the exaggerated lithotomy as opposed to the other variants of lithotomy is thoracolumbar back pain. Magkakaroon din siya if prolonged, of course. So again, these are the variations of the supine position. So for the concerns, the greatest concerns are in the supine position are circulation and pressure points. The most common nerve damages in the supine position is number one, brachial plexus injury, especially if the arms are abducted to more than 90 degrees. The radials and the radial and ulnar nerves may also be compressed against the OR bed and the metal attachments, and the peroneal and the tibial nerves if crossing of the feet and the plantar flexion as the ankle flexes over the feet. So vulnerable bony prominences may cause tissue regional ischemia due to rubbing and sustained pressure, especially over the occiput, the spine, the scapula, the olecranon, the sacrum, and the calcaneus. Pressure alopecia is also a concern for prolonged patients in the supine position for a prolonged period of time. Pressure alopecia is caused by ischemic hair follicles related to prolonged immobilization of the head, with its full weight falling on a limited area, usually the occiput. Pressure alopecia is permanent. So since the follicles have already necrosed at that point. Pero studies have shown that patients in the supine position for more than 18 hours naman po yung nakikita nila where pressure alopecia is being seen. So it's important for us to note that even if the patient is in the supine position, even for short periods of time, it's important for us to lift the head once in a while, tilt the head once in a while, safely of course, while protecting the airway. Backache may also occur because the normal lordotic curvature is often lost during general anesthesia with muscle relaxation or neuratial block. And again, peripheral nerve injuries, particularly brachial plexus injury, radial and ulnar neuropathy. Now we proceed to the lateral positions. The lateral decubitus position is mostly used for surgery involving the thorax, the retroperitoneal structures, or hip, or in one lung ventilation method. The patient rests on the non-operative side and is balanced with anterior and posterior support, usually bed rollings, deflatable bean bags. The patient's head must be kept in a neutral position to prevent excessive lateral rotation of the neck and stretch injuries to the brachial plexus. So I'll be showing you the supports that we need to prepare. Well, you need to prepare when the patient is for the lateral decubitus position. So, the patient is rolled laterally to the non-operative side. So, ito yung non-operative side ng patient. The lower leg is flexed with a padding in between the legs, and both arms are supported and padded. The dependent ear should be checked to avoid folding and undue pressure. The eyes should be securely taped before repositioning and frequently checked for compression. Kidney rest must be properly placed under the patient's dependent iliac rest to prevent compression of the inferior vena cava. Ayun. Usually, ito yung pinapa-prep ng seniors natin sa atin. The axillary roll, especially if the patient is for the lateral decubitus position. To avoid compression of the dependent brachial plexus or blood vessels, an axillary roll is placed between the chest wall and the bed. Pulse should be monitored in the dependent arm for early detection of axillary neurovascular compression. So for the physiological changes in the lateral position, the patient is in the lateral decubitus position. The lateral weight of the mediastinum and the cephalad-abdominal pressure causes overventilation of the non-dependent lung. Coupled with an increased perfusion in the dependent lung due to gravity, these factors would cause a ventilation perfusion mismatch, potentially affecting gas exchange and ventilation. So again, these are the hemodynamic and the respiratory changes in the lateral position. So for the flexed lateral position, the patient may be flexed in the lateral position to spread the ribs towards during thoracotomies and to improve the exposure of the retroperitoneum for renal surgeries. The point of flexion should lie under the iliac crest. Should lie under the iliac crest rather than the flank or the lower ribs to optimize ventilation of the dependent lung. So for the complications of the lateral position, the patient's eyes and ears, the patient's face must be turned towards the mattress and the lids are not okay. That as mentioned kanina, the eyes should be taped para walang corneal abrasion, and that the pinna of the ear should be checked for undue pressure. Baka naka-fold yan ng lateral mo, kawawa naman siya, mawalan siya ng tenga. Direct pressure of the globe can displace the crystalline lens, increase intraocular pressure, and cause ischemia if with systemic hypotension. The weight of the head can press on the downside ear, causing contusions as well. Now, for the prone position, usually this is used dito sa atin sa Quirino, nagpo-prone tayo. Either the jackknife position, which is prone, or prone positioning for neurologic spine surgeries or orthopedic spine surgeries. The prone or the ventral decubitus position is primarily used for surgical access to the posterior fossa of the skull, the posterior spine, the buttocks, the perirectal area, and the lower extremities. The patient's legs should be padded and flexed slightly at the hip. The arms should be tucked sideways, neutrally or on an armboard next to the head, and the head should be supported face down or turned to the side. Remember, sorry, I didn't ngayon ko lang na-notice that the photo that I use is using the Wilson frame. The Wilson frame is actually very notorious for post-operative visual loss. So, wait lang, papakita ko lang mas maayos. Pero, the American Society of Anesthesiologists actually has a technical working group for post-operative vision loss. A very big deal sa kanila, especially, well, pati sa atin. Kasi, especially in the prone position, many patients turn blind post-operatively because of the prone position, among many other things. But it is important for us to try to prevent post-operative vision loss, syempre. According to the ASA Technical Working Group on Post-Operative Vision Loss, they identified several risk factors for POVL or post-operative vision loss. Male sex, obesity, the use of the Wilson surgical frame, this one, the one in the photo, longer anesthetic duration for more than 8 hours, estimated blood loss of more than 3 liters, and a lower percentage of colloid in non-blood fluid administration. If you can see, the Wilson frame, the head is lower than the heart. If the head is lower on the heart, lymphatic and venous drainage is obstructed. If this happens, this causes ischemic optic neuropathy. Magpupool yung lymphatics and blood over the area of the optic nerve, causing permanent vision loss. So kaya yung Wilson frame is very notorious for that. So I'm not saying that we should rule out the Wilson frame entirely, but as a technical working group says that if you do use the Wilson frame, you make sure to lift the head every 15 to 30 minutes to check pressure over the eyes, and then you use a support like this one, yung blue sa yung prone pillow, to try to at least level the head uh, towards the heart, at least magka-level man lang sila. Tama naman dito, naglagay siya ng rolls over the patient's foot. And then, what's important kasi in the prone position is you try to dislodge the abdomen from the actual operating table. This increases, kasi kung hindi, this increases intra-abdominal pressure. If intra-abdominal pressure is increased and the surgeon is open sa likod, sa spine, it is a risk factor of increased intraoperative blood loss also. So it's important for us to pad from the shoulder to the iliac crest bilaterally to lift the abdomen off of the operating table. Okay? And then check lagi, especially kung prone kayo, check the eyes. Dapat walang pressure over the eyes. ASA recommends every 15 to 30 minutes, you lift the head and check the eyes for pressure. And then post-operatively, kapag prone positioning yung patient, you make sure to observe up to the post-operative day 2 for visual checks. Kasi POVL can extend up to the second post-operative day. Okay? Okay. So, ayan. Another photo of careful prone positioning, yung ma-explain ko, all summarized in this photo. And the physiologic changes and other hemodynamic effects of the prone position, which I mentioned already naman. So the goal is to avoid pressure over the abdomen, to minimize compression of the vena cava and the abdominal contents and its associated physiologic changes. So complications of the prone position here. When the head is lower than the heart, venous and the lymphatic stasis in the head causes facial and airway edema, causing possible difficult extubation. Vision loss also because of venous and lymphatic congestion, causing ischemic optic neuropathy. And the eyelid should be closed to avoid accidental separation and scratching of the cornea. Abdominal compression can cause the visor to force the diaphragm cephalad, impairing ventilation, and return of blood from the pelvis and lower extremities may be reduced. So for the head elevated position, we have here the beach chair position. So For the beach chair position, this is usually used for shoulder surgeries, including arthroscopic procedures. The arms must be supported to prevent stretching of the brachial plexus without pressure on the ulnar area of the elbow. Associated with neurologic injury, cervical neopraxia, and hypotensive bradycardia when used epinephrine containing interscalene blockade. In the sitting or the beach chair position, the patient is on their back, the head of the bed raised, the hips are flexed, and the legs are flexed at the knee. It is commonly used for shoulder and posterior fossa craniotomies. So, this is the beach chair position. What's important to note in the beach chair position is the high incidence of venous air embolism. So because of the pooling of the blood in the lower body, kasi nakaupo siya technically patients under GA are prone to the hypotensive episode. So imagine a seated position, a patient na naka-GA, general anesthesia, the blood pools towards the lower extremities, plus nag-GA ka pa, the patients are really very prone to hypotensive episodes. So it's important for us to address those as needed intraoperatively. Excessive cervical flexion can impede arterial and venous blood flow, causing hypoperfusion or venous congestion of the brain. Because of the elevation of the surgical field above the heart and the inability of the dural venous sinuses to collapse because of their bony attachment, the risk of venous air embolism is a constant concern. Ito, in this context, neurosurgical procedure yung ginawa dyan. The inability of the dural venous sinuses to collapse because of their bony attachment. The risk of venous air embolism is a constant concern. But venous air embolism is also a constant concern in shoulder arthroscopies because the distending medium in shoulder arthroscopies is gas. So doon po pwedeng mangyari yung venous air thromboembolism. The source of the air, I mean, would be the distending medium, especially the surgical field is above the right atrium. So if mag-introduce ka ng air sa venous system which in a surgical field above the right atrium, wala. Since vein yan, babalik lang talaga siya sa right atrium mismo. So venous thromboembolism. So this is the summary of the beach chair position, its hemodynamic, respiratory, and physiologic changes. Complications of the head elevated positions, you have postural hypotension, air embolism, edema of the face, tongue and neck. If itong edema of the face, tongue and neck, this occurs because of venous and lymphatic obstruction caused by prolonged and marked neck flexion if wala sa anatomic position yung head ng pasyente. Sciatic nerve injury occurs if the hips are markedly flexed without the knees bent. This can also cause foot drop. Foot drop because the common peroneal nerve is a branch of the sciatic nerve. So for the reverse Trendelenburg position, ito yung head elevated position with the feet down. This causes pooling of blood in the lower extremities and the abdominal vasculature, reducing and decreased stroke volume and cardiac output. This also increases functional residual capacity and lung compliance as the dependent portion of the lungs increases perfusion, and the non-dependent of the lungs ventilation is increased. Okay. So for the head down positions, I'm sorry, last few slides po. This improves exposure of the pelvic organs during abdominal and laparoscopic surgeries. Hemodynamically, this increases venous return, central blood volume, and mean arterial pressure. Respiratory changes include upward displacement of the diaphragm by the abdominal contents, decreases functional residual capacity and lung compliance. In the anesthetized patient, resulting airway closure, VQ mismatch, and atelectasis. Prolonged Trendelenburg position can cause facial and laryngeal edema, and gravitational changes increases intracranial pressure and intraocular pressure. So physiologic considerations include an increase in venous return, cardiac output, and mean arterial pressure. Progressive tilt within the range of less than 45 degrees, filling pressures progressively increase without a significant change in cardiac output or MAP. ICP also increases, and ICP and IOP also increases due to the effect of gravity on the blood flow. Complications include, as mentioned, edema and facial swelling, tongue, laryngeal tissue edema, airway compromise after extubation. Sorry po, ang liit. But this is a summary of the ASA practice advisory for the prevention of perioperative peripheral neuropathies. As apparently in the States, the most commonly sued doctors are anesthesiologists, and the most common reason for such lawsuits are post-operative peripheral neuropathies. That's why ASA has released guidelines on padding and supports for to prevent different peripheral neuropathies from occurring. So almost all of these naman, even almost all of the recommendations set forth by ASA is being done here in Quirino Memorial Medical Center. So this is just a summary of the paddings that we do with specific positions for patients to undergo surgery. So in conclusion, positioning for optimal surgical exposure, but the potential for lasting harm to patients from a proper patient positioning must guide our actions. Each position has significant physiologic effects on ventilation and circulation, and patient positioning is an important matter to be worked on to promote comfort and safety in addition to securing the desired surgical exposure. And these are my references. Thank you po.
Tuloy natin tayo. Sa papel yun sa inyo.
Opo.
Number 9. Most common lower limb nerve injury in dorsal position, as it may be compressed by flare-ups. Most common lower limb nerve injury in dorsal position. Number 10, venous air embolism as a complication of what position? Venous air embolism